talk to you. I thought being a lecture of this type, nothing very didactic, but can you turn my slides on? I picked the topic, the imperative of innovation in cardiac surgery. Innovations are all around us. We are all creative creatures of God. Human beings are basically creative. And it started a long time ago. Henri-Marie René Levy was very innovative. He likely, in the turn of the last century, built one of the best clinics in the world because of detail. Actually, Michael DeBake, before he started being Michael DeBake in Houston, he spent several months in France with Professor Levy. And Michael DeBake soon arrived in Houston. He wrote a paper on Professor Levy, and he said, technical perfection of the delicate manipulations of this master surgeon. And Michael DeBake called him the father of vascular surgery. I like what Michael DeBake wrote, technical perfection. If you aim for perfection, I'll bet you it'll be very good. Only God is perfect. But try to aim for perfection, and the results you provide for a patient will be at least excellent. Unfortunately, unlike other sciences, if you take a look at what happened in the past 2 decades with this iPhone, or any smartphone, or computers, it's very gratifying to the engineers that develop this, because whatever programming they do, they find an answer almost immediately. We don't. We work with life, with biology. Whatever you think you invented today is wonderful, but it has to pass the test of time. And to be quite honest, I learned as a teenager in Africa with Albert Einstein. And we took care of a poor patient with some injury. And he said to me, you have no idea what's going to happen next 20, 30 years, unless you see this patient again. We have to innovate. How do we innovate things? How do we create new things? Well, some of us are very lucky. Our brain is different, but very few of us. So the genius theory that this guy has is a genius. It's very sporadic, very rare. Most of us are hardly working people. We are like Thomas Edison. 99% perspiration, 1% inspiration. That's the importance of providing accurate, detailed outcomes, honest outcomes. That's how we make ourselves better. It's a stepwise. More knowledgeable you are, more likely you are to provide something innovative and better than the past. Let me give an example. The case of the mitral valve. It's a very small area of our culture. Last October, the Brigham and Women's Hospital from Harvard in Boston celebrated 100th anniversary of Cutler's first mitral valve split. You are aware of this. He managed to put a knife inside of the mitral valve, this young girl, and she lived for 4.5 years. And my gosh, only 4.5 years. But wait, this was 100 years ago. 100 years ago, we could see the patient, we talked to the patient, of physical examination. There was an electrocardiogram. But it's not the meaning of most abnormalities of the electrocardiogram. There was just X-rays. was endotracheal intubation for thoracic surgery work in the chest, but very few anesthetic. Remember, in 1923, there's no angiography, no echo, no antibiotics, no monitoring of oxygen saturation. You had to look at the patient's bed nail to see if it was pink or not, or hold the patient's toes to see if it's warm or cold. You're very lucky. We are the final product of hundreds of pioneers. And from 1923, nothing happened to the mitral valve until the 40s, late 40s. Because every attempt made, the patient died. And the cardiologist never sent another patient to surgery. But from 1948 to 62, several brave thoracic surgeons attacked mitral stenosis. And finally, by 1962, Oswald Tubbs came up with a fantastic instrument. This is innovation. Put this thing in the left atrial appendage, palpate the stenosis, put it later to the apex of the heart, and you split. Believe or not, I have done that operation as a resident. Then, of course, an explosion in technology made our life so much more scientifically sound. Angiography, right heart catheterization, and likely for us cardiac surgeons, magnetic resonance, CAT scan, and echo are the best tools. Echo is the best one for us who work in constructive heart surgery because it's portable. You can take to the operating room and see precisely what the lesion is, what we can accomplish with changing the lesion that is making the patient sick. Carpentier made a major difference in mitral valve. I was fortunate enough to work with Carpentier, to learn from him back in the 80s, early 80s. Carpentier was able to classify the lesions that affect mitral valve pathology and cause dysfunction, and introduce several concepts. Nonetheless, the most important one likely was that mitral regurgitation, tricuspid regurgitation, almost invariably comes with anodilation. So anodoplasty is part of the mitral valve repair. Actually, 11 years after he presented the first day in the United States, he was elected to a very prestigious post of the American Association for Thoracic Surgery, became the honorary guest speaker. In that lecture, that he named French correction, to make a joke on a movie that we played here before called the French Connection, because of drug chilling between the United States and France. He used the word French correction, which is very appropriate. He established the principles and taught us how to resect a leaflet. You don't resect a leaflet at random. There must follow some principles. Much more than that, he introduced that when you move the leaflet, you can move a posterior leaflet from one part to the other, as long as you know anatomy and you are able to sever the secondary cord attention to prevent restriction. Carpentier did all that back in the 70s. He even introduced a technique to shorten cord attention. It didn't work too well, but he introduced it. Flip over technique worked very well. It still works well. And of course, as I mentioned before, reduction in the area that the leaflet has to seal likely was the most innovative aspect of mitral valve repair. We are now back in the 70s. Well, we couldn't repair every valve, but the pressure was there to repair a patient with multiple segment prolapse, not only a P2 or A2, complete prolapse. Well, I knew all that. I've been trained by the master. It didn't take very long to introduce Cortex as early as 1985. Initially to repair only anterior leaflet prolapse, because you could resect the posterior, but soon for everything. The technique evolved in no time. You're correcting multiple segments in a single cortex by creating multiple loops. Furthermore, so too complicated. Pre-measure the distance of the loops and create multiple loops as many as you like. I'm not sure it's as good as continuous, but the jury is out there. We need more data on both techniques comparing so you, youngsters, can innovate and make this better than it was in the past. Alfieri had a great idea. If the anterior leaf is prolapsing, secure to the posterior, make a valve with 2 orifices. It works, at least working in his hands. Look what the innovation is all about. In the United States, Alfieri presents a dozen cases of anterior leaf prolapse with clipping or stitching, A2 to P2. Mehmet Oz was in the audience. Immediately, Mehmet Oz went home and filed a patent for the E-clip, the valve clip. Born from an audience like yours, he heard of Fieri or Tavio talk about edge to edge. You see, why to open a page to edge, go to the groin? I don't have to tell you how many millions of dollars Dr. Osman had made this on this patent concept like this. In 1985, a pathologist from Hopkins published a paper that most cardiac surgeons do not read. It's called the mitral hemorrhage disjunction. I happened to read the New England Journal of Medicine every week in those days. I was young. I had to inquire. I had to accumulate knowledge. You can only modify something you're doing if you're knowledgeable. Unless you know everything done, researched, and published, you cannot move science to a higher level. You have to have the foundations of the past. So I saw this. The first patient that I saw with displacement in the echo, I detached the posterior leaflet and was displaced okay. The posterior leaflet became atrialized. Robert Anderson, fellow, wrote a letter to the editor saying, Professor Hutchins is incorrect. There is no mitral displacement. What there isn't is a fibrous annulus. Annulus come from the Latin as a ring, as a band. This is an annulus. But we're sure that you're married or not. This is annulus. Mitral valve doesn't have annulus. Baltic I can show. Victor Solomon in India dissected 200 normal hearts. 180 had no annulus. Had a lateral fibrous trigon, medial fibrous trigon, a band in between, and the amount of fibrous tissue going posteriorly was highly variable. Very few human beings had a complete ring. Well, that put a new spin on Hutchins. If the mitral vein is incomplete, mitral vein displaces a very common entity. Go home next time, look at your P2. At least half of the P2 prolapse are displaced, are atrialized. It's very common. Of course, if you have Barber's disease, if you have an advanced myxoma degeneration, the whole valve can become atrialized. Well, that's called innovation. I had published a paper in 1989 that barbers were associated with a high recurrent mitral regurgitation. In my hands, 20% at 5 years. I was alarmed. Once I saw that, I said, my barbers is failing, not because it's barbers, it's because of the mitral vein displacement. I'm doing an annuloplasty in the atrium. And I knew that Christian Caprol had done mitral valve replacement, securing the mitral valve in the atrium. Disaster. A year or two, they all fell apart. The atrium wasn't meant to tolerate systolic pressure. It dilates, it stretches. So we developed an operation. We detached the whole posterior leaflet, severed all secondary porta tangina and did the annuloplasty in the ventricle. Oh, but you're going to do the circumflex artery. No, there's no circumflex artery in the ventricle. The circumflex artery is an atrial structure. It's outside the heart. As long as your bites are within the heart, you don't get circumflex artery. Knowledge of anatomy. And as a consequence of the mitral displacement, 20 years later, we discovered that mitral anal displacement is a predictor of sudden death, particularly in young patient barrels, particularly women with bileafar prolapse and advanced midstone degeneration. 5 years ago, we published our outcome, personal outcomes of patients that I followed prospectively for 30 years on mitral valve repair. It's published in JACC. Mean follow-up 11 years, 96% complete with echo. These are summary of the outcomes. The red line in the bottom, 12% at 20 years, is the proportion of patients in my hands, my group, that died of heart failure, died from the heart, not cancer, not something else. It came down to 115 cardiac deaths over that period of time. So one death in third after mitral valve repair was cardiac. 25 of them sudden. So mitral valve repair doesn't prevent people from dying suddenly. Of those 25, 4 patients had the head CABG at the same time. One might say, well, their graft failed or progressive disease, and a myocardial infarction to the patient suddenly. Possibly, because they didn't have an autopsy in these patients. However, in multivariable analysis, Barlow's bileafar prolapse and MED was protective against sudden death, telling me that moving the posterior leaflet to inside the ventricle protects the patient against sudden death, protects young women and patients with Barlow's and mitral anal displacement. This is learned from experience. It's a stepwise education. If I had not changed the aperture technique in 1986, when I learned from Dr. Hutchins that mitral anal displacement is a entity, I wouldn't have come to this conclusion. The mitral anal is calcified, particularly as they get older, particularly in women, and especially in patient with Barlow's disease. In Barlow's is very simple because the anus is displaced, the calcification is away from the heart. It's easier to detach the leaflet, remove the calcium bar, and reattach the leaflet like you do normally. However, in patient with fibrinolysis deficiency, the calcification extended into the muscle. So you have to shave the muscle out to be able to repair this. There's a video missing here, I apologize for that. Back to our long-term outcomes. We had only a 4.6% reoperation in mitral valve, very low reoperation rate. At 20 years, 4.6% require mitral valve intervention. Yeah, but it might be leaking. No, they're not leaking. We do work in every patient. Severe MR was only in 3% of the patients, and the rest were moderate. But moderate, I guess, if you wait long enough, you might transform into severe. But 20 years later, only 12.5% had recurrent MR. So not bad results, particularly since they include all patients, Barlow's, calcified mitral annulus, and everything else we do to save a mitral valve. If you take a look at multivariate analysis, why people who had mitral valve repair develop recurrent MR? Well, longer you follow them, more likely you are to have. So time. For every year, there's an incremental risk that the disease might progress or something that you have done in the operating room falls apart. The second is very rare. If you do a proper job, only progression of the disease bring the patient back. But I want you to look at the bottom there. Patients who have advanced mixed-cell degeneration are 3 times more likely to develop recurrent MR. This is a very advanced disease that many surgeons do not repair. Most surgeons repair isolated segments, 1 or 2 segments. This is a meta-analysis, all the papers published on repair of P2 by resection that Carpentier described, or by the way Fred Moore described with multiple chorda. Look at the graphs on the left side of the recurrent MR for all patients, and for the risk of adjust patients. 18% have recurrent MR at 5 years. 18%. I reported 12 at 20 years. And all comers, half of them have complex repair, calcified microanus, Barlow's, MAD. Take a look at resection on your chorda, makes no difference in a dilated ventricle by another author. So if the recurrent MR is close to 20% at 5 to 10 years, it's no wonder that TEER is taking over mitral valve repair. That's an innovation that's going to affect us, surgeons, and the patients too, unless you provide perfect results or outstanding clinical outcomes in mitral valve repair. There are 2 ongoing randomized trials in North America now. One NIH funded, the other one funded by Abbott. The one funded by Abbott is aired in television, in newspaper, in lay media. They tell the patient in lay media, private newspaper, do you have mitral regurgitation? Ask your doctor if you're a candidate for CLIP. The power of money. The power of interfering. I don't know about it in Turkey or in Europe. In North America, there are 2 commercials now that dominate television. Cars and medicine, drugs, cancer therapy, arthritis therapy, advertising lay media to influence the patient to tell the doctor what to use. Actually, Abbott, if you log on, they say more. They say, in the randomized endovascular valve edge-to-edge studies of Everest 2, which I was part of it, a transcatheter mitral leaflet approximation mitral clip device, the Abbott device, now Abbott, wasn't Abbott before, was safer than surgical mitral valve repair. I have 3,000 mitral valve repair. I lost 4 patients in the first 5 years of my practice. I haven't lost a mitral valve repair since 1985. They don't die. They're young people. They're healthy people. But even those sick in pulmonary edema, they don't die. Mitral valve repair doesn't kill patients. But in a randomized trial, it killed. And they're saying, but does not effective in reducing MR. I don't profess I know the future, I can see the future, but both randomized trials in the United States are going to show no difference in outcome. There'll be no inferiority. There'll be same mortality, likely lower mortality with the clip, but the same amount of recurrent mitral regurgitation. Because we don't do a good job. We repair a P2, 5 years later, 18% are leaking. This P2 is a fallacy. Something is wrong. I hate to say that, but it's wrong with us doctors. We don't know how to do the operation. It's football season in the States began now. and Miss Lombard was a great coach. He used to tell the players, perfection is not attainable, but if you chase perfection, we can attain, can catch excellence. We have to be excellent cardiac surgeons to compete with competing technologies. And the tier is going to test how good we are in repairing a mitral valve. I have to thank the Professor Soy for the privilege of giving this brief lecture. I know he's late, you don't want to hear much more from